ready to start, go for it.
All right, it's 12:16. We can go ahead and get rolling. So hopefully today is going to be an abbreviated version of today's performance, but we'll see how much information we have and go wherever this takes us. So the biggest thing I want to talk about today are the anticipated effects of the end of the public health emergency. So for those who haven't heard, the federal government or President Biden has announced that as of May 11th, we are no longer dealing with COVID. So COVID is cured. Yay, us. So maybe that's not completely fair. The public health emergency will expire on May 11th. And if you are not just bored out of your skull and have nothing better to do with your life, you may not have read through the explicit detail of what all that will bring to a closure. So I wanted to summarize the key points that will affect us and most of our practices. A lot of the things will still have a rollout of expiration dates, as I'll kind of explain going forward. But I'll kind of start at the ones that everyone probably has the most concern about. So telehealth coverage, remember that was kind of a non-existent pre-pandemic. Then during the pandemic, the public health emergency really kind of paved the way for equity for telehealth coverage. And a lot of the payers have largely said they will remain at par until the end of the public health emergency. Most of them have indicated they will continue to follow the guidance of what Medicare intends to do. So I can't remember, several resolutions ago, Congress passed a stipulation that 150 days after the public health emergency, the telehealth parity would remain. So even after May 11th, we still have another 150-day window where telehealth parity will remain for Medicare, and most of the payers are anticipated that they will follow suit with that. There is a lot of effort and discussion. In fact, there was some discussion that it may even be included in this new budget amendment that they would come forward, that potentially that would be added to that, as there seems to be support from both parties and both houses of Congress to extend that permanent. But as of yet, that has not been firmly established. So telehealth parity should remain past May 11th and likely for at least another 150 days. And then hopefully there will be an extension thereafter, but we won't know the full effects of that. The bigger things that we are likely to see in practice are up until this point. In fact, probably most of us have taken advantage. If you wanted at-home COVID testing, you could order up to 8 at a time from the government or from your payer or from a pharmacy that would get charged back to your payer, and it would get covered at no cost to the patient. That will sunset on May 11th. So at-home COVID tests will still be covered. For private payers, the general consensus is that most will likely provide coverage, not 100%, but provide coverage, but potentially from a narrower network of suppliers. So, right now you can call and see whatever the pharmacy has available, and you can order them, and you can drop by and pick up to 8 at a time. And I think it's like every month that you might be able to do that. It's quite a large volume of tests that you can order. Going forward, there may be a charge per test, and it may not be just whatever's available in the pharmacy. You may only be able to order 2 or 3, and it may be mail order supply only. So that, and with Medicare, the cost of those tests will get passed on to the beneficiary. For uninsured, it will no longer be covered. So up until this point, you could get tests anywhere, or you could order them and they would be covered. That will no longer be the case for the uninsured population. For vaccines, because vaccines are still federally purchased, vaccines will still be available at no cost. So vaccines and boosters for COVID for the indefinite foreseeable future will still be available at no cost to those who elect to get them. But Paxlovid and the antiviral therapies will not be covered. So they They will be covered as a kind of like a pharmaceutical would currently. The federal government has said that they will continue to cover them at cost through the Medicare program until their supply runs out. And then after that, it would basically be a pharmacy benefit program thereafter. So that obviously affects some. Antiviral therapies, in the hospitals, there are none currently approved, so that's not really an applicable discussion at the moment. So that doesn't matter. In states outside of New York, so New York is one of the few states where Medicaid benefits were retained for COVID. And throughout the country, the federal government offered grants to states to maintain their Medicaid program as long as they did not drop anyone from their Medicaid roster from pre-pandemic. So many states took advantage of that. Many states, especially in the Southeast, Southwest, will no longer be getting federal subsidies at the conclusion of the public health emergency. So they will no longer retain or be forced to retain patients on their Medicaid benefits programs. So the estimate, like in California, it's estimated that 5 to 15 million people alone may drop off of Medicaid in the state of California. New York is one of the states where the Medicaid benefits will persist. So unlikely that we will see any change for our patient population. But what does that mean for folks who are coming in, who are receiving care because they're traveling employment or vacationing or whatever the case may be? There may be a good number of people who will lose their Medicaid benefits at the conclusion of this. For some of the emergency use authorizations, some of the allowances for staffing and the like, that will sunset. So in New York, I'll use the nursing homes as an example. This will not really apply to us because there have been some leniencies around staffing mandates and the like in nursing homes that the federal government eased as far as Medicare reimbursement. That will sunset at the conclusion of the May 11th date. New York had already enacted those staffing minimums for New York State nursing homes. So I don't think that should cause a significant increase in nursing home problems above what we're already seeing. So our state probably will not be as affected, but we will see that in other states. Pennsylvania, for instance, that did not enact the state did not enact the staffing mandates for nursing homes. When the federal government allowances expired, they will be held to those staffing mandates for Medicare reimbursement, which pretty much all have to follow. So, what will that do for us? It's an interesting conversation about nursing staffing and the like, where people were, at one point fleeing New York State because of vaccine mandates and staffing allowances. Now that will become much more equitable at the conclusion of that May 11th termination, unless there is some incremental extension. And I should say, with everything I'm saying, that is what would happen today if tomorrow was May 12th. Obviously, any one of these things could become a political hot potato and be included, but likely not all of them at this point. Trying to think, is there anything else I wanted to mention? The only other piece that will end that doesn't really affect us directly, unless there's folks on here from hospitals, but the Medicare had offered a 20% premium on reimbursement for any COVID care that hospitals provided. That will terminate as of May 11th. So COVID will no longer have any extra reimbursement provided to hospitals, which all of our hospitals are not in financial strong situations at the moment, but all our hospitals are not seeing huge COVID volumes either. So I don't think that will be a huge effect in our region unless we see another surge of COVID in the future, and we'll see what comes there. So there will be some effects. Again, nothing is going to change between now and May 11th. Folks who have been asking, friends, family, I've been telling folks now is the time to stock up on your home COVID tests because they are free for now. I will advise, and most of you probably are more aware of this than I am. The expiration date on those is not terribly forgiving. And I have seen several, in fact, I was at UHS last week, and they have baskets of them that they're offering for folks to take one if you want it, because they're getting close to their expiration date. So it's probably not something people want to just order 8 per month per family member and stock up, because they won't last forever. But certainly for those who are using them for, going back to work or sending kids to school or the like, there likely will be a cost associated with them, or a little bit more of a restriction on which test your insurance will cover once that public health emergency expires. So there's still a couple months left to stock up on those while we can. And I expect there's been a little bit more willy-nilly use of Paxlovid up to this point, even in populations that probably aren't necessarily the most in need. And so I think most likely we'll see a little bit tightening of the utilization of Paxlovid only to those groups where there's proven benefit, which certainly, your average 35-year-old that doesn't have a lot of health issues is probably not someone that should be prescribed Paxlovid, and certainly not when there's an out-of-pocket cost associated with it. So those are conversations that likely will be coming up more in May. But until that point, we are safe on telehealth for the foreseeable future. Likely will not see an issue with that until we get into summer. And we may see some movement before that time, especially as there seemed to be a little bit warm and fuzzy last night between the president and both houses and parties around what they may be able to do and not in touching entitlements and healthcare. So maybe that'll carry over as they look to blow past the debt ceiling and blow all of our great grandchildren's money for years to come. So more to come on that. I'm not in charge of that, can't speak to it, but use it while you got it, I guess is what I'm saying. So that's really all I wanted to bring forward. The only, there has been questions about boosters. I think the FDA came out and basically talked about moving to an annual booster program for the COVID vaccines, for all the immunogenicity discussions we had before, and for the what appears to be the longevity versus the kind of community exposure that we may be getting from COVID transmission. There's probably good reason to say the annual booster, much like a flu shot type program, probably has some strength to it as far as recommendation, without causing immune suppression and immune response because of repeated and maybe too frequently repeated exposure to boosters potential that we talked about before. So I have not heard a timeline of when the annual booster program may come to fruition, but that does seem to be what the consensus is moving towards. As far as updates on masking, we will fall to the New York State guidance on that, and that the Department of Health is still pretty adamant that there will be masking in any healthcare providing location. So I do not think that we're going to see any change to that in the foreseeable future. I will say, and this is something that we're wrestling with at the university level right now, with the stay or the current appeal of the New York State vaccine mandate for healthcare workers. There was quite a bit of legal discussion, and the general consensus is that there likely is reason that we have to allow religious exemptions in New York State for the vaccine mandate during the time where this stay of the vaccine mandate is in place. New York State has indicated they plan to appeal and fight to reinstate the mandate. But it does open a situation where if there were employees who filed for religious exemption or chose to pursue a religious exemption and then ultimately were denied religious exemption when the vaccine mandate went into place, now those folks could and should be reoffered a religious exemption if they so chose, with the understanding that if they are, right now there's no mandate. That's a great question. So there is still a mandate that for New York State, but the religious exemption must be allowed. I know that's probably clear as mud. And let me preempt this by saying, I am not an attorney. Please do not take this as legal advice. And I will tell you, every time I have this conversation with someone, I get more confused. So I can tell you that there is a vaccine mandate that anyone who is hired must have completed the initial series. They are not held to the booster. However, if they would put forward a religious exemption, you would have to show due diligence that you considered that. If you are acknowledging the Church of Chad as an acceptable religious exemption, then please feel free to move forward with hiring my congregation. So that is up to the individual employer as to what that due diligence means. But previously, New York State had not recognized a religious exemption. And so therefore that was not included. With this current stay, those who would seek religious exemption could and should do so, understanding that if New York State appeals and is successful, they would intend to remove the religious exemption once again. So you may have to voluntarily terminate that person from the Church of Chad at a later date. So I think, we have to be honest and open with those folks, but there is a narrow window right now where if folks would like to claim a religious exemption, there is that avenue for them to do so. So I will now be quiet and go tend to my congregation, and I will turn it over to LJ.
So I just want to say I am a proud member of the Church of Chad congregation. I seriously miss these not being weekly tune-ins to the YouTube channel that features Chad. Seriously, Chad, thank you for summarizing what you did, because that is so complicated what's happening with the end of the public health emergency. And I think it was very nicely summarized. And I appreciate your honesty where things are not clear, because they're not. They haven't been for a long time. My piece in this is pretty brief. Gina is going to share some slides for me. Essentially, I'm just going to give you a quick update that was shared with the Children's Hospital, because we had been in that insane triple-demic of viruses that has settled down now. You can go to the next slide, Gina. These are Tim Stevens' slides. I want to give him credit for that. And I sort of summarized them really quickly. Basically, in current trends, I think all of you and many of you are caring for kids who are on the screen. I was looking at the people who are represented here. You know from your workflows in your practice, the decreased volume of illness visits, that things have settled. And but this is sort of from the view of the Children's Hospital, that cases and hospitalizations are low without change now for RSV, low and falling for influenza, and then the COVID cases stable. Not gone, right, Chad? But the hospitalization rates are falling, and that's, for our county in general. The one point I wanted to make to the teams who are caring for kids is that the end date for Synagis, because I'm not even going to try to say and stutter on that word, but the end date for Synagis may actually be earlier than typically done. So stay tuned. There'll be some kind of messaging that'll come out from Peds Infectious Disease as they determine that, but the cases are so low now that it really becomes a risk-benefit ratio of whether they continue through the end of March as normal, or whether they may actually suspend Synagis injections before that time. Next slide. Thanks. And this was just the county COVID cases per 100,000. This is just our county data, just as an illustration of that. And you can go on to the next one. And then just really quick, you were all living this, the GCH team was living this, sort of the system being completely overwhelmed, patients leaving the ED without being seen, not having enough space in your practices. But I wanted to give you a quick census update for Gulf Center Children's, for those of you who wonder how things are, and we are finally, for the last couple of weeks, back to normal census, and normal census is usually over 100% now in the Children's Hospital. But this just gives a little bit of information about where patients are The ED has been doing well in keeping up with the volume of patients, and things are not overflowing into other spaces in the hospital and not having patients doubled up in rooms where they're not usually doubled rooms. So it feels like everybody is taking a little bit of a collective breath, and we sincerely hope that that has been the same for your teams. I know your work is never done because you're always doing preventive care and acute care, but hopefully there's a little bit of space. And I think that was all I had, Jana. There really isn't much else on the peds end to update on. Renee?
Okay, great, thanks. As folks might recall, when we started slowing down the cadence of our COVID calls, we kind of changed the branding on this call to a AHP update call. While it's still our time to share lots of information about COVID, we also want to use it to just share information that we think is useful to you, or possibly even something that we need some action from you. So to share my screen, can everyone see that? Looks good. Yeah. Okay. I wanted to just provide a couple of quick updates. First of all, 2023 quality measures. This was an article in our most recent network news, but I still am getting lots of emails inquiring about 2023 quality measures. So I just wanted to let folks know that, they are available. These are the same measures as the 2022 grid. They may have updated definitions, although I don't know if any of them have a new definition. Definitely, though, updated thresholds for 2023. Arcadia will be updated with the new thresholds around March, but we do already have up on ahpnetwork.com the updated detailed measure pages. And I just want to very quickly show you how to find that information. You're just going to go to ahpnetwork.com and click on partner resources up there on the top. That brings you to this page where in that bar up there right under partner resources, you'll select quality measures. And then that brings you to this page of the 2023 measures. And so these are all the ones that are on our provider facing grid. And you will see, if you click on one, I selected adolescent immunization. This is the detailed measure that detailed measure page gives you information about the measure and also highlights what are the changes in terms of the thresholds. So for example, for adolescent immunization, for 2023, the bar has been risen to achieve the 90th percentile. It went up 2.47 percentages. So just wanted to make folks aware that that's where they can find information about the 2023 measures. We'll keep talking to you about this. We're still implementing the PER across the network, which is another place where you can find information about your performance. Any questions about this, please feel free to reach out to me or to Elizabeth Sharp as far as the specifics of a measure. Also wanted to let folks know who are on the call who perhaps are working with an AHP care manager. We are asking for your assistance, like in prior years, with providing feedback on your experience working with an AHP care manager. So for those of you that have that are adult practices that have an embedded RN adult care manager, we sent out a survey via SurveyMonkey on January 26th to all the providers in the office and the practice manager for a brief survey to get some feedback on your experience of working with your care manager and if applicable, a data coordinator. And the surveys for those adult care managers are due back on Friday, February 10th. If you didn't receive a survey and you do work with an AHP adult care manager, please reach out to me and we'll see what happened there and make sure you get an opportunity to share your feedback, your experience working with that individual. For our practices who are working with an AHP pediatric social work care manager, a similar survey is going to be sent out next week, same way via SurveyMonkey to those providers and practice managers. And we appreciate your sharing that feedback. It's important that we know what your experience is in order to have a well-rounded performance review for these folks. Any questions, please just let me know. And 1099s, we also get a lot of questions. It's tax season, yay. And people are asking about their 1099s. So just want to reinforce that these were already sent out to practices on or around January 27th, and those come from our consultant Bonadio group. We also issue 1099s to individual providers who participate on our AHP advisory committees or on our board, but it is only sent to those who earn $600 or more in those meeting stipends. So if you serve on an AHP committee and you didn't receive an individual 1099 from us, then you probably earned less than $600 in stipends for 2022. But if you have any questions about that, you're welcome to give me a call and we will check it out. And then finally, this isn't really an AHP update, but I saw this on our UR Medicine intranet, and I thought it might be of interest to practices to be aware of some updated security measures that were put in place at the Strong ED. And this is part of a multi-phase hospital-wide security program that started in October 2022, unfortunately in response to some of those incidents at hospitals across the country. So as it relates to the Strong ED, the newest part of their new security measures just went operational on Monday, and that is the implementation of a concealed weapons detection system. So that just began this week. And then other security enhancements have included giving control switches on the automatic sliding doors. So those can be turned off. The automatic nature of them can be turned off by staff in an emergency, and also some improvements to physical barriers. So all efforts to keep staff and patients safer in the Strong ED. So just wanted to share that with you in case it was of interest. Those were all of my updates, and please let me know if you have any questions about that.
Perfect. One more just generally good parting story to give you something to feel good about in life. For those who thought that COVID was the worst thing we'd have to worry about in 2023, good news, H5N1 is back. So our bird flu friend of old. Just last week, they had discovered that not only does it cause $9 eggs per dozen, but it also has now transferred into mammals for the first time in several years. So there are otters and sea lions that are running around with bird flu. And when it shows the ability to cross over into mammals, that is if you go back, when we dealt with bird flu before, that was when it actually showed the infection to humans. And I forgot that the mortality rate of bird flu, although the transmission was very low, mortality rate of bird flu was as high as 50% at one point. So all that stuff we learned for COVID, we might still get the opportunity to use it again for bird flu. So hang on to your hats, folks. This is going to be fun. So there you go.
Can I just add, we're going to work with Pastor Chad on inspirational messages to close with, and perhaps we'll revamp that for next time. Oh my gosh, you are not controllable. Okay.
So
everybody have a great week.
If anybody's got any sea lions at home, don't pet them anytime soon.